There's so much confusing and conflicting information out there around pregnancy and birth, and none of it comes from the people that are actually in the room. We are Sarah and Catherine, two Canadian labor and delivery nurses with over 4,500 births under our belts.
What if the nurse holding your hand during labor could also answer every question you were too nervous to ask your doctor?
Welcome to 4,500 births later. We have Dr. COVID with K, Lee, in the house tonight.
Okay, this is quite a hot topic. A lot of people want to know what makes you, as the obstetrician, want to intervene in the sense of how do you decide it's time for a cesarean section?
I think so. That's a pretty loaded question. That's a really good question too, because obviously there's a lot of different indications for cesarean section, the urgency of it, the timing of it all as well. I think it really all depends on a couple factors, as in why we're inducing in the first place, if they're being induced, how the labor is progressing, how the baby's been looking throughout the entire labor, how mom's doing throughout the entire labor as well. My general opinion with regard to kind of timing of cesarean sections, and I'll kind of make it simple. So obviously for fetal heart rate indications, let's just say the fetal heart rate's going down, it's not really resolving. A lot of times if a patient's not even in labor and I see kind of these heart rate issues, I like to just kind of plant the seed just so that there's no surprises. A lot of times with my approach with a lot of patients is that if I'm a little bit worried about the fetal heart rate very, very early in labor, I sometimes just talk about it. And I also kind of review the consent with them. So kind of a mini prax. Even though I kind of say, hey, we're not going for a C-section yet, but I would just like to explain the process to you. Sometimes it allows kind of patients just to kind of wrap their heads around it, because I mean, when it comes to obstetrics, things have to happen pretty quickly, as you guys know. And not all the time do you have that luxury to kind of go through a very, very well-informed consent where patients really know kind of what they're getting themselves into. And sometimes things can be pretty scary where we actually have to act pretty quickly. And those are the situations that obviously I think everyone would like to avoid. But I think if we're more preemptive and proactive in the way that, hey, you know what, I think I'm a little bit worried about this baby. Sometimes I'll just, again, talk about it. And sometimes I even offer, hey, you know what, if you guys are comfortable with it, we can just get you to sign the consent form, just so that it's kind of like getting the formality out of the way. But then knowing that if we have to come back and reassess and we realize that the heart rate's not getting any better, that we can just kind of move along with the C-section in a more kind of, I'd say, timely fashion. What I usually kind of also take into account, though, because again, every labor is different, is whether it's the first time that the patient is pregnant versus if they've had vaginal deliveries in the past, whether or not their cervix is changing, whether or not the baby's looked perfect before. So a lot of times when we see heart rate issues, I always talk about whether or not that baby's gas tank has a lot left. So a lot of times when we see, let's just say, dips in the heart rate, obviously no one likes to see dips in the heart rate, but sometimes they're physiologically normal. And a lot of times we see the heart rate recover. And that to me tells me that that baby still has a lot left in the gas tank and that we can push this baby a little bit more if we needed to. And obviously we have techniques to try to get maybe mom or baby over those humps if they kind of have those repeated dips, but we're seeing changes in the cervix. Talking about kind of going back to seeing kind of abnormal fetal heart rates early in labor and talking about inductions again. So reasons why they're in labor, reasons why we're putting them into labor. So maybe for small babies or for maybe babies that don't have a lot of fluid around them. Again, those ones kind of I like to talk about, well, you know, and I sometimes offer them too. If this baby is not even potentially tolerating a cervical ripening process where we're just opening up the cervix or the cervix isn't even open yet or they're not even in labor, I do broach that subject as well. When it comes to, so the ones that are trickier are more kind of the protracted first stages. So patients that have maybe not progressed over hours, but the patient's perfect and the baby's perfect. Those ones can be, I think, a little bit more tricky in my practice. And again, obviously every pregnancy and every labor is different as well. But I usually say if you're perfect and your baby's perfect, I'm happy to give you all the time in the world. When things change, though, that's when my tone will change. So what I mean by that is, you know, we can give you all the time in the world, but if the heart rate starts to all of a sudden become atypical or abnormal, or let's just say all of a sudden maybe if mom develops a fever or she's starting to feel, or if she's just tired, because I mean, labor itself is a marathon, but so is postpartum. And I think that a lot of people also fail to to kind of recognize that even though that labor is, however long it could be, we talked about maybe days for an induction. After they deliver and meet that baby, they're going to be up and they're going to be sleep deprived as well. So keeping it in account, and I always kind of ask, how's mom doing? How motivated is she to still have a vaginal delivery? And if the motivation's still there, and again, if they're doing well and the baby's doing well, I'm happy to give a lot of extra time. Again, kind of going back to oxytocin and kind of the protocols, 20 milliunits per minute is kind of the low dose protocol, but I'm happy and willing to go higher if the patient wants to, understanding that, again, and practicing them accordingly and letting them know that, hey, if we do this longer, there might be a risk of infection or there might be a risk of bleeding for you after. But as long as mom and baby are both happy and as long as mom's informed, then I'm happy to kind of make a shared decision amongst kind of everybody. So.
Mm-hmm. You kind of already touched on this with the fetal heart rate, but when is a C-section clearly the safest option?
I'll be honest. I mean, we don't always know, and we're not always perfect either. So a lot of times we'll do C-sections, and I'm sure you guys have seen this because we've seen awful heart rates, and the baby comes out crying, screaming, and the cord gas is over 725. Sometimes we'll do C-sections, and what I talked about before, mom's perfect, baby's perfect, the heart rate's beautiful, but the mom's tired. We do a C-section, the baby comes out flat, and the cord gas is less than 7. There's actually been kind of some studies that say with heart rate, and we can talk about that too another time, but how accurate and how good is interpreting a fetal heart rate and the outcome of kind of baby. But to be honest, like there isn't really I think a really clear cut answer to any of that. And I know too, with a lot of my colleagues, and I actually, and maybe I could share something anecdotal with you, but when I was a 5th-year resident, I remember that there was heart rate tracing that I wasn't really comfortable with, but my mentor, who's been in practice for 20 plus years, is just like, you know what, COVID, like I think this heart rate's okay. Like I think we could sit on this baby a little bit longer. And then the mom got a vaginal delivery. The baby did great, and I kind of was a little bit like, well, did I really read that scenario wrong? And could I have approached this a little bit differently? And my mentor said, if you're ever worried about the baby, it's never wrong to talk about and discuss and have a cesarean section. And the truth is, and she mentioned this too, is I'd rather be wrong and do a cesarean section and have a happy crying baby rather than be right and have a vaginal delivery and that baby comes out flat. Yeah. So she said it's never really a wrong decision as long as it's an informed decision amongst everybody where they agree and they're aware of the risks and benefits of having a cesarean section. And again, I think it is really just a shared informed decision amongst everybody. But I think the best time to have that conversation is either when you're maybe suspicious for it and it's not necessarily kind of in a stat situation where really sometimes patients and families don't really have any time to process anything and they're really just kind of at the mercy at the obstetrician and the nurse is kind of making the decision almost for them in a way. So yeah.
So how do you handle those situations when some seem to be really anti-cesarean section?
Yeah.
And so when you're concerned about that baby's heartbeat and everybody else is concerned about that baby's heartbeat and the patient is, no, I do not want a cesarean section.
Yeah.
How do you handle those situations?
Those situations can definitely be difficult to navigate. But I think an aspect of our job that I think we just have to respect patient autonomy and understand that this is their pregnancy, this is their baby. The best that we can do is let them know kind of the risks involved with potentially continuing the pregnancy with a trial labor versus a cesarean section. Knowing potentially the risks, not only kind of short term, but long term as well. Because I mean, a lot of times too, and I mean, you can't blame patients that, when they're in the zone and they're focused, they're anyone who's in a labor and delivery room really at the end of the day wants a trial labor. They want a vaginal delivery. And I always keep that in mind because that is their goal now. Is that their number one goal? Everyone's a little bit different. And I do think that, and this is the beauty of our job, is I think that really every labor is special and every patient and every baby is so different. And I think that what I love about this job is that I think just respecting that patient autonomy and approaching every labor differently. Because I mean, how often have we seen kind of the heart rates that are bad, or how often have we seen kind of, let's just say, an arrest of progress where there's just no change? But how often have we seen so many different outcomes in both those scenarios, right? And I think that's just why I love this job so much. And I do think that what's really important for what we need to do is not only obviously express kind of what we're concerned about, but also hearing kind of what their concerns are and obviously understanding where they're coming from as well. Now, I know that in a like idealistic world, we have all the time in the world to do that, and sometimes that's not always the case. Sometimes in those cases, I will kind of express my acute concern with having this baby. And I do talk about kind of the risks, not only short term, but long term as well. And a lot of times, if the patient still refuses, it's not to say that I'm just going to withdraw care from that patient. I'm still going to care for that patient and I'm going to look after them all the same. But that's not to say that I might come back in 20 minutes and still offer a cesarean section and have that same conversation with them if I'm still worried about that baby. Yeah.
Okay. Thank you.
Okay. I think a lot of people have questions around, a lot of fear around our forceps and vacuums. Are you recommending this because it's truly necessary? And is there preference among obstetricians on methods of delivery?
Yeah, I think so. So again, I mean, there's always indications for everything. So even kind of going back to kind of your cesarean section question, there is always indications for an operative vaginal delivery. Sometimes there's indications where patients, even though they can have a vaginal delivery, are actually not recommended to push. So sometimes in those cases, we absolutely recommend an operative vaginal delivery. Sometimes for patients, it can be that they've been pushing for a long time and it's not necessarily a lack of effort, and it's not necessarily ineffective pushing. It's just a change of the angle. Sometimes it's for heart rate issues and concerns as well. Um, I think choice of instrument definitely lies in, I'd say, practitioners' comfort levels as well. I mean, it's not to say that I also have hard rules as well. And obviously, it comes down to also patient consent as well. So, understanding what the risks are with having any kind of operative delivery, whether it's forceps vacuum, and they both carry their own risks. And again, it's every patient's preference as well, but they can always have a cesarean section. Now, when I talk about kind of my operative deliveries, I always talk about a cesarean section is always an option, but depending on how well the mom is pushing, depending on how low the baby is, depending on the baby's position, sometimes I will say that I do think that it's safer to try for a vaginal delivery now that we've made it this far, because a cesarean section still has its risks, even in the second stage. And sometimes those risks can be bigger because a lot of times it can be difficult to get an impacted head out of the pelvis, because if you think about it, kind of our incision is up here, but the baby's head could be so low that lifting that baby's head can be traumatizing. But a lot of times we do say that there's risk to baby potentially getting that baby out of the pelvis and toward the incision. There's also a risk to mom and bleeding as a result of that and damage to adjacent organs, because when you have to reach so low, sometimes there's a lot more unanticipated tearing as well. So for that reason, it's not that a cesarean section is always the safest option. Again, it very much is an informed consent, and it very much is a combined decision amongst everybody. I do kind of offer what my recommendation is to be the safest option for patients, and they can say no, and that's every right for them too. So I could, and sometimes this has happened to me where I'm like, I think the safest option for your baby is a forceps delivery, and some patients just do not want an operative vaginal delivery for their reasons, and reasons that I can absolutely empathize with. And cesarean section it is, as long as they're aware of kind of the risks. Um, but yeah, I do think that when it comes to forceps and vacuum, now there are certain indications where we actually don't recommend maybe a vacuum. So maybe issues with mom with maybe an undiagnosed bleeding disorder, where we think that maybe it could be passed on to baby, just because a vacuum does inherently carry higher risk technically to baby than forceps. The biggest thing that we do worry about is kind of bleeding underneath the scalp. But a lot of times too, it's practitioner comfort levels and what they're comfortable with and how they feel. And I do think at the end of the day, all doctors will only offer and do what they're comfortable with. And that's, I mean, me too, where if I feel like I cannot deliver that baby safely down below, I will recommend a cesarean section for those reasons too.
So what are some risks of having a forceps vacuum delivery?
The risks, I mean, so there's multiple different risks. And we always talk about risks to baby and to mom as well. Um, Forceps, and this is kind of what I tell my patients, that if forceps are put on properly, and the application is good, then the risk to baby is very, very small. And I kind of give, well, my usual kind of preamble is that if I can't get the forceps on properly, or if I don't feel like I have a good application of the forceps, I would actually abandon the procedure and just recommend a cesarean section at that time. But in general, forceps is safer for baby, obviously if done correctly, but definitely higher risk to mom. So higher risk of having what we call an oasis tear. So a tear potentially into the bum. And oftentimes we might recommend an episiotomy or just a cut away from the bum, just to encourage the tear to go to the path of least resistance. Obviously, with any kind of operative delivery too, usually more so with forceps, there can be issues with incontinence, prolapse, pelvic floor dysfunction down the road as well. So again, this is kind of all part of the prax procedure, where it's what is the sequelae of having a forceps delivery. When you think about kind of a vacuum, that's a suction cup that goes on baby's head. So sometimes if baby has a lot of swelling, that can accentuate that swelling. And again, the biggest risk that we worry about is kind of bleeding. Babies, again, they don't have a lot of reserve when it comes to blood volume. And if babies bleed briskly and quickly, they could potentially bleed out their entire blood volume just in their head alone. So a lot of times with vacuum, that would be the bigger risk to baby. That being said, we also have criteria when it comes to vacuum. So we only set a certain amount of pressure. We also give ourselves only a certain amount of attempts or pulls. After a certain amount of time, or after maybe a certain amount of pop-offs, we say, hey, you know what? This is not working. This is no longer safe for your baby. We kind of have to switch gears. With regard to the vacuum, though, it does not expand the pelvic outlet. So what I mean by that is that the vacuum is smaller than the baby's head, whereas the forceps go on the outside of the baby's head, which is why obviously it causes a little bit more trauma to the pelvic floor. But with a vacuum, because it's smaller, um, vacuums tend to pose less issues with pelvic floor dysfunction, incontinence, and prolapse as maybe compared to forceps. That being said, because it's an expedited delivery, there hasn't been a lot of time for tissue to stretch, all that stuff as well. Operative deliveries in general lend themselves more to issues with pelvic floor dysfunction down the road. But I actually offer and I recommend for all my patients, even if they have cesarean sections, pelvic floor physiotherapy 6 weeks postpartum, as long as obviously they've healed from, let's just say, their tear or their cesarean section. And the reason why is because even the act of being pregnant changes your pelvic floor. So, I mean, technically, a cesarean section is more protective to your pelvic floor than a vaginal delivery. But that being said, even having a cesarean section, just the act of having and carrying a pregnancy puts different stresses and strains on your pelvic floor, on your anatomy, and it does change things going forward as well. So
That's so progressive of you to be recommending that.
oh yeah,
I love it.
yeah, thank you. I'm doing Kegels right now.
And we don't even know.
Okay, I have a big one. The biggest question.
Give it to me.
Buckle up.
I like this. I like this. Is it personal?
Could be.
These are the best questions.
Okay, so to end off here.
Yeah.
What do you wish as an obstetrician that patients understood?
Oh, good question. Nothing. I love having conversations with my patients, and I think that's why I fell in love with this specialty. I think everyone has such a different approach to their pregnancy, to their baby, how they got there, their journey. And I think part of that journey just doesn't end with our conversation. And I don't think it ends with labor. And I don't think it ends, let's just say, if they just want a book cesarean section. I love actually when patients Google things. I know that a lot of people are like, oh, I was told not to Dr. Google, but I love it because that's where we actually have more conversation. And that's where I'm like, you know what? There actually is a little bit of medical evidence to that. Or, you know what? That might just be a little bit anecdotal. Or, you know what? There's not a lot of medical evidence for that, but it shows that it doesn't really do any harm. Versus, you know what? I would maybe avoid that. There's actually been studies to show that might do harm. So I kind of like having every patient kind of come in with at least an open mind. But I also like kind of the patients that have a sense of direction and they kind of know where they want to go. They have kind of that knowledge and that knowledge base where it's a forum for us to kind of catapult a little bit of discussion. But that's what makes, in my opinion, this specialty perfect, is because every single prenatal visit with every single patient is going to be different, whether it's, the 36-week routine Group B strep swab and saying, I'm going to start seeing you weekly. Everyone is really different in how they kind of tackle their pregnancy, what their goals are, what they want their outcomes to be, and what they want to prioritize, how they want their experience to be. And I love hearing it all, because I'm learning something from my patients every day as well. So I I don't want any expectation of my patients, and I actually like it when they do come in, and sometimes I like it when they want to challenge me a little bit or ask more questions, because when I see that they're asking questions, I know that they're interested and they want to know. And it's not to say that they're telling me what they want to do. They want to know what my perspective is, and they want it to really be, at the end of the day, a team decision, because really, if they didn't want my opinion, they wouldn't talk to me about it. So I really actually do appreciate all those open-ended questions, the challenging questions, just even sometimes advice and recommendations, on what I would do. So yeah, I have no expectation, and that is my expectation.
I like that answer.
Yeah.
Very good.
Thanks.
I love
Can
that.
I ask one more?
No.
This one might be harder. As an obstetrician, can be a really tough job at times. How do you deal with the difficult cases that you inevitably encounter?
Yeah, that's a really good question too, because I find that this specialty is a very thankful specialty, and fortunately, 99% of the time, it is kind of happy, good outcomes, but it obviously is not always that case. But I do find that, and I can only speak to kind of the Rocky View and my call group and my family and my friends, but I think we have a very, very strong group at the Rocky View. I'm also very proud to be part of my call group as well. I think that we're very, very collegial. We support each other all the time. Um, and I also find that when it comes to kind of the more kind of traumatic or difficult deliveries, just being open with the patients as well, having those debriefing sessions, seeing them in follow up. I find that that can be healing, um, not only for obviously the patients, but for me as well. So yeah, obviously we want, and in our job, we're always hoping for kind of the best outcomes for baby and for mom. But when it doesn't come out that way, or when it doesn't happen that way, I do think that we have a really strong family at the Rocky View Hospital. And I am very thankful to have kind of colleagues like you guys. And again, obstetricians and gynecologists in my group as well that are very, very supportive and trusting of kind of our decision making. And really, at the end of the day, I think it comes down to kind of the support that we have and the ability to know that, even though that we're in this job to have potentially the best outcomes, there are complications that do happen, and we do have to understand that and recognize that, and knowing how we can just get better with each and every one. So a lot of times too, we have official debriefs, or sometimes we have what we call morbidity or mortality rounds, where we review these difficult cases, and it's not necessarily kind of pointing the finger at anybody, but saying, hey, is this a process issue? How can we make things better? What could we maybe do better so that we can avoid these situations going forward? And I find that it is a continual learning experience for everybody, not just specifically for the people that are involved in this case, but people can learn from other people as well. So I just would say that the family that I have at the Rocky View Hospital, obviously my family at home as well, but my colleagues, I think we just have a very collegial environment that really fosters like a professional learning environment, that is non-judgmental. So it does help in that way.
Thank you for sharing that.
Yeah.
Yeah, thank you.
And thank you for being here tonight.
Thank you.
Yeah.
Thanks for having me, guys. That was awesome.
Very interesting stuff.
Thank you.
Thanks for sharing.
Yeah.
We've really enjoyed having you here, and thanks for popping over after putting your kids to bed.
Yeah, this was
and
awesome.
chatting with
Have
us.
me again, please.
We'll have you back.
Okay, cool.
Thank
If you have any questions about what you heard today, please reach out. Sarah and I would love to hear from you. Email us at birthslater@yahoo.com. That's birthslater@yahoo.com. We are here to support you every step of the way. And now for the legal language. This podcast is solely for educational and entertainment purposes. This podcast is not intended as a substitute for professional advice from qualified individuals involved in your prenatal, labor, and postnatal care. Every pregnancy and birth is different, so always talk to your healthcare provider about what's right for you.